right, everybody, welcome back for part 2 of chapter 45. In this part or portion of the lecture, we're going to really be focusing on hypercapnic ventilatory failure or respiratory failure, um, and then kind of some of the things that signify the need for mechanical ventilation support. And you're going to get kind of a basic overview of non-invasive ventilation and then invasive ventilation. So, hypercapnic ventilatory failure or respiratory failure is when you have that presence of that elevated CO2 um, or carbon dioxide, which is creating uncompensated respiratory acidosis. So here's kind of an example of what one of those ABGs would look like. Okay, so again, this is just a refresher back about ABGs from last semester. So you see that pH of 7.30, which you should identify as acidotic. The acidosis is being caused by this elevated CO2 of 55. And it's uncompensated because my bicarb is still within a normal limit. Okay, this would be classified as uncompensated respiratory acidosis with normal oximetry, with that PaO2 being above 80. Okay, so sometimes this is referred to as pump failure or ventilatory failure. I usually refer to this as ventilatory failure. That's why I keep messing up and saying that instead of respiratory failure, because really this is an issue with ventilation. We're not ventilating enough to eliminate the CO2 from our body. So this can happen also chronically. So this is this uncompensated respiratory acidosis above here. This would be acute because you don't have that renal compensation, but you can also have a chronic elevation of CO2. This happens in a lot. We see this a lot in our COPD patients. So you would see an ABG that looks like this, with our pH falling within the normal range, but on the acidotic side of that normal range at 7.35. Our PCO2 is elevated at 67, but our bicarb is also elevated at 30, which balances itself out. That's why we have that normal pH. So this would be considered still respiratory acidosis, but it's fully compensated or chronic respiratory acidosis, or sometimes it's called chronic ventilatory failure. Okay, and then our PaO2 here in this example is 80, but typically what you would see with the COPD is that PaO2 being in that mild hypoxemic range of 60 to 80. That would be probably a more accurate representation than what I have in here right now, but I didn't want to confuse you guys by throwing oximetry into it, hypoxemia into it. Okay, so this chronic elevated CO2 sometimes can result in an acute phase on top of it, where we call that acute on chronic ventilatory failure. And that's an example here in the second ABG or third ABG on this slide, where we see that CO2 elevating even higher to 75. Our bicarb doesn't have a chance to compensate quickly. So we see that drop in pH down to 7.32. And now we're not this is not a normal ABG. It's not fully compensated anymore. So we have this again uncompensated respiratory acidosis, which signifies that acute ventilatory failure on top of the chronic issue. Okay, so this figure from your book, or one similar to that, is just showing you how the relationship between CO2 and that alveolar ventilation. So these are inversely proportional. So meaning as alveolar ventilation goes up, CO2 goes down. So, which makes sense, right? If I breathe deeper, I breathe faster, I'm going to eliminate more CO2 from my body, so that PaCO2 value will go down. Okay, don't worry ever about the math of this. I will never, ever, ever expect you to know this. It's just a nice representation to show you how that mathematically this correlates, and you can kind of predict what your pH or what your CO2 will be based on how much minute ventilation you have. Okay. So when you're talking about minute ventilation or alveolar ventilation, remember this is the amount of ventilation that's happening at that alveolar level. So you need to remove that anatomic dead space from the tidal volume. Okay, so this is a tip for your worksheet. There's a question on there that asks you to calculate out the patient's anatomic dead space, and then they're given their ideal body weight, and then calculate out their alveolar minute ventilation. So anatomic dead space again is going to be, here's your hint, anatomic dead space is going to be equal to, hopefully you guys remember this. Ooh, God, I hate when that happens. 1 milliliter per pound, ideal body weight. So if I give you an ideal body weight of 150 pounds, then 150 milliliters is what that patient's anatomic dead space is. Okay, then if I give you the, I will have to have given you the tidal volume too. So let's say the patient's 150 pounds. So that equals 150 milliliters. I take that, subtract it from the total tidal volume. So let's say our tidal volume is 550 minus 150. That gives me, I like nice easy math, 300. Oh my goodness. That equals 300 milliliters. Okay, so that's my new tidal volume. That's my alveolar tidal volume. Now I know my alveolar tidal volume. I just multiply that by the respiratory rate given. So if my respiratory rate was, let's say 20, then that means my minute ventilation will be 6 liters per minute. Okay. So again, we've done that in the past. That should be a little bit of a refresher. And that is one question on your worksheet relates to that. All right. So then your book talks about why else you might have high levels of carbon dioxide that aren't ventilation related. So these are very uncommon. So this would not be the first go-to guess of what was wrong with your patient. If you have a high CO2, the common culprit is decreased ventilation, but it can also be because the patient has been exposed to high levels of carbon dioxide. So this can be post surgical patients when they're in they're under anesthesia. There's CO2 scrubbers that are inside that anesthesia machine circuitry. They're supposed to help remove the CO2 so the patient doesn't rebreathe it. If those are defective, then the patient is going to rebreathe CO2 and have an elevated carbon dioxide level without an issue with ventilation. That also can happen in scuba diving equipment and other types of submersible or airtight crafts. Anywhere that you potentially would be rebreathing the air that you're exhaling, you need to have some sort of CO2 removal system in there in order to not rebreathe that carbon dioxide. There also are some occupational exposures. So spelunkers in caves, individuals that work with dry ice or miners or firefighters sometimes can be exposed to high levels of carbon dioxide. Okay. Clinically, you might see, and this can actually kind of happen in some of your patients, commonly found in patients that are already in the ICU, where they have that increased carbon dioxide production. And I think I alluded to this a little bit earlier. So our body's purpose of ventilation is to remove the carbon dioxide that's produced in the tissues. So sometimes our body's producing excessive amounts of carbon dioxide. So anything that's causing our metabolism to increase or our bodies to have to produce more energy is going to increase the amount of carbon dioxide we're producing. So if you think about it, we're going to need more energy if we have a fever, to increase our body temperature. If we're agitated or we're exerting a lot of energy through exercise or shivering, seizure patients, things like that, hypermetabolism. All of those things are going to cause or potentially cause this increase in CO2 production. Also, excessive calorie intake. This is something just to note that most of our patients that are in the ICU that are really severe COPDers, it's usually like the super severe COPDers. We watch their diets. They're usually on a low carbohydrate, high fat diet, and that's not only to help that's not to necessarily control their blood sugar like a diabetic, but to help reduce the amount of carbon dioxide that's produced from breaking down those carbohydrates in the patient's body. We also can see issues with ventilation not related to lung function, but CNS function. So impairment of those respiratory control systems. So that central nervous system and those peripheral chemoreceptors are responsible for, our drive to breathe. We learned about that last semester. If you have taken certain kinds of drugs or sedatives, that can affect your central nervous system's ability to send signals to increase breathing, rate and depth of breathing. If you have issues with your brainstem where a lot of these central nervous system controls are located, that's going to affect your breathing, controls of breathing. Diseases of the central nervous system like multiple sclerosis or Parkinson's disease can cause respiratory depression, hypothyroidism, patients with morbid obesity and sleep apnea. Those diseases sometimes can affect those peripheral chemoreceptors and slow down your rate of breathing. So, pretty clinical hallmark of this when these patients are presenting, they're going to be bradypneic. I have such a hard time saying that word. So that means that your respiratory rate is lower than normal, so less than like 12 beats per minute, breaths per minute. And then ultimately you can have apneas, or you can have some of those weird breathing patterns like Shane Stokes breathing or apneutic breathing, gasping respirations. All of those are abnormal breathing patterns that can be a sign of CNS issues. So typically when you notice a patient that's coming in, respiratory rate really low or an irregular breathing pattern with that lower respiratory rate, you're going to want to start suspecting some sort of CNS issue. So you want to get a good history of anything the patient might have taken or anything that might have happened to the patient. Probably toxicology is always done on these types of patients. So that's a lab test if they're looking for different substances in the body. And usually like a CT MRI of the brain and neck is usually ordered to help with diagnosis. All right. So we can also have like an impairment of the kind of neurological diseases can impair our exhaled carbon dioxide. So, this is where those central nervous system will send out the impulses to tell us to breathe deeper or faster, but somewhere along the pathways, the message gets corrupted and doesn't ever make it to the lungs. So this is very common in patients with like spinal trauma. We talked about that, right? C3 to C5 is where that phrenic nerve comes out. So if you ever have a spinal cord injury at or above that level, there's going to be partial or complete paralysis of that phrenic nerve and the inability then to ventilate on their own. There's also motor neuron disorders like ALS or Lou Gehrig's disease that affect that nerve transmission. You have Guillain-Barré syndrome that also affects the nerves, motor neurons. Uh, Myasthenia gravis and botulism are disorders that affect that junction, neuromuscular junction. So as that nerve ending, and then muscular diseases like muscular dystrophy and meiosis can also like impair the signal got transmitted, but the muscles aren't working the way they're supposed to, and that makes it hard to ventilate. You're going to have a whole chapter on neuromuscular diseases in respiratory disease, so you're going to learn a lot more about how each of these diseases affects lung function. So typically these patients might present kind of varied depending on which disorder it is. So ALS, usually these patients have like a weak cough, they might be drooling. Guillain-Barré syndrome, that is usually the big hallmark of that is you have had the lower extremity weakness that's progressing upward. I always remember somebody's taught this to me once. Guillain-Barré is ground to brain, so lower extremities, periphery up to the top, up to the head. Myasthenia gravis is opposite, so it's mind to ground, where you see that ocular muscle weakness. That's usually the hallmark. You have some facial or eye muscle weakness around the eyes. Ptosis, dysphagia, those are all usually issues with the patient's ability. Muscles in the neck and the face are usually the hallmarks of myasthenia gravis. So they're going to have those difficult clinical presentations, but very common with all of them is that it's going to result in respiratory muscle fatigue and eventually ventilatory failure. Okay, so these are patients going to present different. How you diagnose them, how you treat them is going to be different. Like the medical treatment of them is going to be different. But the things we do as a respiratory therapist for all neuromuscular diseases are fairly similar. You know, you're going to be monitoring their respiratory muscle strength and looking for signs of that ventilatory failure, and then supporting them once there's evidence of that ventilatory failure. Okay, so the next one is just talking about increased work of breathing. So in increased work of breathing, you might have like a normal respiratory drive, normal neural transmission, everything's working, they're getting the signals through, but still there's hypercapnic failure can occur if that respiratory muscles get overworked. Okay. So if the muscles in the respiratory system are being asked to do too much work and they can't overcome that work, you're going to start seeing that increase in the CO2 level. Like I said before, your body is never going to go into an energy deficit just to breathe or just to do any of its body functions. It doesn't think anything is important enough to expend unnecessary energy or too much energy. So if the energy it takes to breathe is more than the energy that breathing brings in, the lungs aren't going to do, they're going to slow down. The body's going to say, hey, you're doing too much. Let's cut our losses, slow down the breathing, conserve our energy. That's the choice it's going to make 100% of the time. Okay. So, you might see this increased work of breathing where the patient's trying really hard to keep up with the demand and get the CO2 out, but eventually it's going to tire out. It's commonly occurs with the patients that have, you know, that increased dead space to tidal volume ratios and COPD. So like if you have a COPDer that then gets a big community acquired pneumonia where you've got all this dead space ventilation in there from the pneumonia, they're going to start breathing faster because they're not going to be able to get as much volume in. They're only going to be able to do that for so long before they're going to get fatigued and then slow their rate back down and their CO2s are going to climb. That also happens with the presence of that increased airway resistance in our asthma patients. If you think about it, those asthma patients have to work against that resistance. So if you think about a straw and you're trying to blow through a straw and blow all your air out through a straw, you're going to use more force and work harder to blow that air out through like a coffee stirrer size straw than you would through like a big, huge shake straw. So, same thing. As that airway resistance increases in asthmatic patients, they are going to need to use a lot more work, a lot more energy to get the air out of their lungs. Um, we're going to talk a lot more about intrinsic PEEP and auto PEEP throughout this entire semester. I'm going to kind of demonstrate this on a ventilator. I have a good slide on the next page. Next slide has a good picture to kind of talk about that a little bit more. But intrinsic PEEP any type of auto PEEP is going to generate excessive work of breathing because the patient has to overcome that pressure that's already in the lungs in order to change their volume. Other types of disorders that may cause that increased work of breathing are things like pneumothorax, rib fractures, because it's changing that structure of the chest wall. I tried to impose on you guys in last semester how important the shape and rigidity of our chest wall is to effective breathing. So if we break a bunch of ribs and then all of a sudden we have this floppy part of our chest, we're going to have to work much harder to breathe. Pneumothorax, that's going to increase our dead space. That's going to make it difficult for us to breathe, decrease our lung compliance. Pleural effusions, increase dead space, increase our work of breathing. And then again, those hypermetabolic states, which we talked about before, where we have that increased production of CO2, that happens a lot in burn patients. So burn patients, they're a big mess. Severe burn patients, their body is producing a lot of carbon dioxide in that healing process. All right, so this is that slide about intrinsic PEEP or auto PEEP. So those terms are interchangeable. So when we put patient on the ventilator, we put them on something called PEEP, which is our positive and expiratory pressure. And many of you might have seen this when you were doing your clinical rotations this summer. This is a pressure that, if you think about it, it's a pressure that stays in my lungs after exhalation to kind of keep those alveoli open. Okay, so this is like normal. I always am going to have some pressure in there to keep those alveoli open. So we'll always have some PEEP. Okay, when we put our patients on the ventilator, we add PEEP to them. Okay, you're always going to set some level of PEEP. Most of you have probably seen 5 of PEEP, 5 of PEEP, 5 of PEEP. There is more of a science and a finesse to setting your PEEP than just always setting a patient on 5 of PEEP. And I will talk a lot more about this. There's a lot of studies out there that shows people tries to tell people to stop being scared of setting higher PEEPs on our patients. We used to be terrified of setting PEEP on our patients. We want to do the minimum possible always. But now we want to set what we call optimal PEEP, which we will talk again about a lot this semester later on. But you're going to set that PEEP, whether it's optimal PEEP or 5 a PEEP, whatever it is. That's just trying to keep those alveoli open while the patient's on the ventilator. Okay. On top of that, patient can create, whether they're on the vent or not, something called auto PEEP or intrinsic PEEP. This happens when the gas in our lungs doesn't come out the way it's supposed to. So if you see this auto PEEP alveoli, that's a lot fuller than this normal alveoli. Okay. So this happens because my patient gets volume in to this alveoli, which fills it up nice and full. But then when it's time to exhale, they're not able to exhale it down to what a normal resting size would be. So that gas stays in there. And then when the patient takes another deep breath in, that tries to fill up that already full alveoli, and it makes it difficult to get new fresh air in. Old stale air fill it, taking up room there. And there's lots of complications. But that's kind of the idea. So auto PEEP is, instead of going back to the normal resting size of the alveoli, which is still slightly open, that unexhaled volume of gas creates pressure in that alveoli because that air wasn't able to get exhaled. Okay. So this is very, very common in our COPD patients or asthmatic patients will have some level of auto PEEP. There's a lot of different ways that we need to treat it, but big takeaway for you guys right now is that you need to understand that in order for me to get more air in this alveoli that has this extra PEEP in it, my body has to not only has to be able to still create that pressure gradient. So the pressure inside here or up here has to be more than the pressure in here, or the negative, if I'm not on the ventilator and I'm using negative pressure to breathe, I have to create enough negative pressure around this to overcome the positive pressure in that alveoli. So that pressure gradient has to be able to still be made in order for flow to happen. So that's why you have that increased work of breathing, because my muscles have to work that much harder to create that bigger pressure gradient for that volume to enter those lungs. Hopefully that makes sense. We will keep talking about this, and please don't be shy through anything this entire semester. I know that these lectures aren't in person, but some of these concepts are a pretty big deal. So I'm trying to think of all the different ways to explain it in the recording. But if I'm losing you and you're not getting it, please, 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 please bring it up in lab. There's going to be a couple of things that I'm going to just bring up automatically because I'm just like, I know you're not getting it just because, or likelihood that you're not getting it. But, don't be shy about bringing those types of things to my attention, because I want to make sure you're understanding these fundamental, kind of philosophies behind ventilation early on. All right, so then we're moving on to that increased work of breathing clinical presentation. So if you think about it, these are like the typical patients you've seen over the summer. These are the ones you see in the emergency room that are coming in. They're breathing really, really fast, really, really shallow. And that is the big red flag that things are going to go south quick and they're going to go into ventilatory failure. So that rapid shallow breathing usually indicates that there's some issue with like air resistance or compliance in the lungs that's causing that increased work of breathing to happen. And as I breathe more shallow, remember back to that alveolar ventilation, dead space ventilation, as I breathe more shallow, that tidal volume decreases. So my scenario before, we talked about that patient who had a tidal volume of 550, an anatomic dead space of 150, and that they were breathing at 20 times a minute, which was a minute ventilation of 6 overall. Okay, well, now let's talk about that same patient and say their respiratory rate now has gone up to 30, but their tidal volume has now decreased to, let's say it decreased to 300. Okay, so now their tidal volume is 300. I still have to remove that 150 of anatomical dead space. So that now is only 150 that's getting to alveolar ventilation. 150 times 30 breaths times 1.15 is 150 milliliters. That's only 4.5 liters per minute for our minute ventilation. So that is not adequate for an adult. Okay, so that patient's probably going to be running into some really severe hypercapnia where CO2 levels are going to start climbing. So typically, because of that shallow breathing too, your breath sounds are going to be fairly diminished in the bases. Diminished breath sounds in asthmatic patients is always going to be a pretty big sign of a bad problem. Because remember, diminished means that you're not hearing enough air moving to even create that whistling wheeze effect. Patients that have increased work of breathing and that have those higher CO2 levels are going to be irritable. They might be confused. And if the symptoms are bad enough, they're going to end up being kind of comatose, lethargic, obtunded. Whenever your body is under a lot of stress, it releases those catecholamides. These, like another word for catecholamides is like epinephrine or norepinephrine. These can cause like muscle tremors. And then because your CO2 levels are increasing, this can cause something called vasodilation. So as my CO2 levels increase, my blood vessels in my brain dilate. So more blood flow goes to my brain. That's going to cause swelling around the optic nerve and cause something called papilledema. So we're talking about chronic ventilatory failure. This is ventilatory failure that happens over months and years. So this is always related to like a chronic condition, usually your COPDers, or chronic hypoventilation syndrome that's related to obesity. So as that CO2 is elevated over that long period of time, our body develops compensation mechanisms, which we know from CP-Phys is that renal compensation. Okay, so the renal compensation is going to start happening where our kidneys are going to start retaining more bicarbonate. Okay, so this sorry, I lost my train of thought here. This can result in like polycythemia. So patients who have chronic like hypoxemia will end up with polycythemia, where the body compensates by increasing the hemoglobin level. It's also going to cause that oxyhemoglobin curve. Boy, I'm bringing that up a lot in this chapter to shift to the right. Okay, so if you remember, that right shift of that curve means that hemoglobin has a decreased affinity for oxygen, which is normally what we want to see at the tissue level, where that hemoglobin wants to kind of unload the oxygen at the tissue levels. But if the curve shifts to the right all the time, that means that the hemoglobin is going to be less likely to pick up the oxygen from the lungs. Okay. Chronic hypoxemia can also cause that cerebral blood flow again. Those cerebral blood vessels are going to dilate, and that cerebral blood flow is going to increase, which can lead to increased intracranial pressures if the patient has other underlying issues. Okay, so like I said, that hypercapnic chronic ventilatory failure, that renal response is to retain bicarb with the goal to normalize the pH. Okay, so it's not going to bring the pH all the way back to that perfect midline of 7.4, but it's going to get it somewhere in that 7.35, 7.39 range. Okay, it's never going to pass, we're never going to compensate past the midpoint. This is kind of irrelevant. This is just kind of an acute ventilatory failure. You can estimate that the pH is going to decrease by 0.08 for every increase in 10 of the CO2. That's just a relationship that's known. Sometimes people use this to understand if there's other factors at play. Okay, so if we kind of know that, my patient's got a CO2 of 55 and their pH, instead of being, so an increase of 10, so instead of being 7.4, now it's 7.32. That's where it should be based on this relationship. But if it's really 7.24, then I start thinking that maybe we're dealing with mixed acidosis and not just simply respiratory acidosis. So that's why these relationships are important. I feel like that's pretty advanced respiratory care when you get into the granular level of trying to understand acid-base balance, which I don't expect any of you to be at right now, but just wanted to kind of explain that a little bit because it was mentioned in your chapter. Okay, so acute on chronic ventilatory failure, we talked about this already. This is where you have that chronic failure that's complicated by an acute issue on top of it. So this is most commonly brought on by, you have a COPD patient who then gets a bacterial viral infection, just gets pneumonia. then they're going to end up in the hospital with that acute ventilation issue. Or a lot of times, you should learn in disease about the relationship between congestive heart failure and COPD. Both of those diseases are kind of interrelated. A lot of patients have the diagnosis of both. So a lot of times you'll have that COPD patient who then goes into congestive heart failure exacerbation and then ends up in the hospital, or anybody that has gets a pulmonary embolism, has any type of chest wall dysfunction, or this is a good one, the non-compliant with treatment patients. So these patients can't be really judged by normal ABG criteria. Okay, we have to look at kind of the significant changes from their baseline. So those values that you think about with, like, okay, if their PCO2 is above 55, that says they're in vent failure and they need to be intubated. Well, if they're a chronic COPD patient, their CO2 is always above 55. That doesn't necessarily mean they need to be intubated, because you need to look at the pH. Always, 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 we are looking to normalize the pH, not the CO2. Okay, if my goal is to normalize the CO2 in a patient who is chronically has an elevated CO2, I can make them do whatever I want to make them do on the ventilator. But what's going to happen is I have no control over how much of that bicarb the kidneys retain. So if I drop their CO2 back between that range of 35 and 45, and now their bicarb is still 30, because it's been 30 for the last 5 years, it's going to take a long time for that bicarb to come back down. So by dropping their CO2 down within the normal range, now I've probably created a metabolic alkalosis situation. So you don't want to normalize the CO2. You're always looking to normalize the pH on these patients. Okay, that's the important part. Other goals are to make sure they're oxygenating well, keeping that SaO2 above 90%. Doing anything that we can to improve airflow. So if there's a COPD patient or an COPD patient, breathing treatments, anything that we can do to improve, reduce bronchospasm, or suctioning the patient to remove any obstructions, that's going to improve our airflow. We want to treat that infection with antibiotics to try to resolve the infection if there's a pneumonia that's causing all these issues. We don't want to overdo it with the fluids. Respiratory patients, cardiac respiratory patients, a lot of times we need to be very careful about how much fluid we give them, because that fluid, too much fluid makes its way into lung tissues, and that does nobody any favors. And then preventing or treating any complications as necessary is another important piece of this. So when you're talking about the complications of acute ventilatory failure, it's important to note that any type of complications that happens is going to increase the morbidity and mortality of our patients. I can't say this enough. It's really important to understand, and just to understand that mechanical ventilation doesn't treat anything. I'm never going, oh, my patient is a COPD patient, I need to put them on the mechanical ventilator to treat their COPD. I'm not treating their COPD by putting them on the ventilator. All I'm doing by putting them on the ventilator is to buying ourselves some time for those other therapies to work to improve the patient's underlying conditions. Okay, so the ventilator just buys us time. And our best goal with the ventilator is to remember that it's buying us time, and the best thing we can do is to try to avoid all the complications that are associated with mechanical ventilation when our patients are on it, okay, which are numerous. So, we've talked about VAP before, ventilator-associated pneumonia, but there's a lot of other complications that can happen when your patient's on long-term ventilation. So our goal is always to try to get them off of it as quick as possible. You can also end up patients ARDS, or adult respiratory distress syndrome, which you're going to talk about in disease and in this class quite a bit. These patients are have to be managed on the ventilator very carefully in order to improve their likelihood of survival and reducing their risk of like multi-organ failure. Because with ARDS, sepsis is usually one of the reasons why ARDS happens, and it's just like this inflammatory process in the lungs. And if you think about it, my lungs are already inflamed. If I'm pounding positive pressure into those inflamed lungs, I'm going to make that inflammation worse. So I need to be very conscientious when I'm ventilating those patients. Emboli, because patients that are on ventilators in the ICU are usually very sedentary. They're at risk for developing emboli, so we want to reduce our risks of those by prophylactically treating for DVTs or deep vein thromboses. We want to make sure that we're very conscientious about the amount of pressure we're applying to the lungs so we don't create barotrauma. We already talked about infection, and then there's a host of non-pulmonary complications that can be cardiac in nature. We can cause arrhythmias or hypotension with applying too much pressure to that thoracic cavity. You can have gastrointestinal complications for your critical care patients. Again, if they're intubated, they're not really eating, so they have a gut and they're usually on sedation, pain meds that affect gut motility, which can cause blockages, hemorrhages, things like that if you're not careful. And then if the heart and the lungs don't like a lot of excess fluids, but your kidneys really, really like fluid. So a lot of times patients, and I think I talked about this in a couple of your case studies, is that a lot of times patients are show evidence of renal failure due to the fact that we're dehydrating them because of their cardiopulmonary status. So that's like they're in acute renal failure because we're making them that way because we're dehydrating them. So that's a common complication as well that we just need to be cognizant of. So clinically, patients with that respiratory muscle fatigue may present with tachypnea. That's kind of that cardinal sign of that increased work of breathing. They can have like worsening fatigue where the respiratory rate starts kind of decreasing then. And they so after they start getting tired out, their respiratory rate's going to fall. You can even see some apneas. You can also see something called respiratory alterans, which are where the patient's, altering between doing regular respirations with their rib cage and the respiratory muscles, and then that abdominal breathing, which is a sign of respiratory muscle failure or fatigue, where they're using those accessory muscles in their abdomen for inspiration because their thoracic muscles are too tired out. When the patient gets into that full ventilatory failure, you're going to, really want to get those ABGs to look for that hypercapnia with that presence of acidosis. I will say though, a lot of times if you have a patient that's presenting like this, that ABG isn't really necessary, because if you have a patient that comes in looking like this, even if that ABG comes back perfect, I'm thinking to myself, ooh, they're never going to make it that long. They're working this hard to get a normal ABG. They're never going to be able to sustain it. That's what we call kind of impending ventilatory failure, where their ABG looks pretty normal, but all the other signs and symptoms point to we're going to tire out eventually. This train's going to hit the wall and we're going to fall apart. So we might as well intubate early to avoid that. All right. So kind of the goal of ventilatory support is I really stress this table on page 45.3, and I've highlighted some important ones that you need to just make yourself a flashcard about and start committing to memory. Because when it comes to board exams and some of the questions I'm going to be asking you over the semester, you want to be very systematic. And sometimes people get really lost in the weeds when you just need to go back to the basics of like, okay, if my ABG says this, then I'm intubating. And some of those kind of bullet pointed pieces of advice are in these next couple slides. So the goal of mechanical ventilation is always to be supportive therapy until the underlying problem resolves. Okay. So I said that before, I'm saying it again. It's supportive therapy. We're just trying to do the least harm to the patient while the underlying problem resolves. The other goal of mechanical ventilation is sometimes to provide that long-term support. So those are the patients that we know are never coming off the ventilator. They need the ventilator because they've had like a spinal cord injury, or they have advanced neuromuscular disorders like ALS, and they're not going to be able to breathe independently on their own anymore. So we're putting them on the vent to help their ventilation long term. Okay. Mechanical ventilation is used to improve that alveolar ventilation, making sure that enough volume gets down to that alveolar level to provide adequate ventilation. It also is to improve arterial oxygenation. We want to make sure there's adequate amount of oxygen that gets into our blood from our lungs. Okay. We're looking at increasing the volume in our lungs. So just how much volume stays in our lungs, that helps with that alveolar ventilation, that helps with keeping our lungs open, preventing atelectasis, improving oxygenation, and reducing that work of breathing. Okay. So depending on the type of patient, you are going to the choices you make with ventilation are going to be aimed to those patients' specific needs. I'm going to ventilate a patient with ARDS a lot different than I'm going to ventilate somebody with normal lung tissue with just a spinal cord injury. Those two patients are going to be ventilated drastically different. And we're going to talk a little bit more about the disease states in both of your classes this semester and how ventilation can be maximized to improve their outcomes. So in that table on page 980, table 45.3, it gives you these kind of bullet points, your inadequate alveolar ventilation, and then it mentions the kind of values that indicate that. So that's your CO2 being less or greater than 55, and your pH being less than 7.2. Okay, you want those to be both. Because again, our COPD patients can have those really, really high CO2s and a normal pH, and we're not intubating those people. Inadequate lung expansion. So patients that have low tidal volumes, so if their tidal volumes are less than 5 milliliters per kilogram, their vital capacity is less than 10 milliliters per kilogram, their respiratory rate's higher than 35, that tells us that we're in that rapid shallow breathing, that we don't have good lung expansion. Inadequate muscle strength. This is a measurement of, these are the big ones for our neuromuscular patients. So we're going to do something called a MIP, which is our maximum inspiratory pressure. So how strong I can breathe in. Okay, so the more negative the number, the better it is. Okay. If they can't at least make a negative 20, then that means that their inspiratory muscle strength is inadequate. And that's a sign of impending ventilatory failure and the need for mechanical ventilation. So if ever you get a neuromuscular patient scenario and their MIP is negative 15, you're intubating. I don't care about any other information about the patient's getting intubated. If their MIP is negative 30, they're good, continue to monitor. And same thing with vital capacity. Increased work of breathing. This is shown with that minute ventilation or dead space ventilation. Hypoxemia is calculated out by AA gradient, which we talked about in the first slideshow, and your PF ratio, which we're going to talk about here in a minute. Okay, so your hypoxemic respiratory failure. This is a common indication for intubation and mechanical ventilation. So we want that AA gradient greater than 350 on 100% oxygen. So you have to put the patient on 100% oxygen to do this calculation. You're also going to need to get an ABG to get that PaO2 level. PF ratio is a really quick and easy one to do at any FiO2 level. This is the one I use the most at the bedside. I would strongly recommend sometimes if you're in your scenarios and you're like, what is wrong with this patient? Just calculate the PF ratio really quick. And if it is less than 200, your patient has ARDS and you need to be in that ARDS algorithm. So, this PF ratio is extremely easy to calculate. You're just taking that PaO2 from your ABG, dividing it by the FiO2. And then if it's less than 200, that means that your patient has like respiratory distress syndrome and excessive amounts of lung inflammation and needs to be treated appropriately. One I added that wasn't mentioned in your book, but I've seen in other references is severe hypoxemia. So if you have an ABG that comes back and the PaO2 on any, even room air, is 40 or less, you're not monkeying around with like trying to put them on supplemental oxygen. You should probably just intubate. So frequently you will see hypoxemic and hypercapnic respiratory failure happening at the same time. So it's not uncommon to see both. Like, oh, it's not an either or. A lot of times you're seeing this in both patients. Okay, so calculating your PF ratio, this is just, again, just breaking it down for you a little bit further, just in case there's some confusion. So this is that arterial tension of oxygen to inspired oxygen concentration. Oh, I'm sorry. And this is kind of a simplified method to estimate the degree of that interpulmonary shunting. Okay, so the amount of fluid and stuff like that that's in the lungs with that interpulmonary shunting. So if I gave you a PaO2 of 50 and an FiO2 of 40%, you're going to take that 50, divide it by 0.4, and then that gets you 150 millimeters of mercury, which is less than 200, which is indicating that the patient is in that hypoxic respiratory failure. Okay, so that hypercapnic respiratory failure, this is that elevated CO2, may or may not indicate the need for ventilatory support because of those COPD patients or those chronic patients. So CO2 of greater than 55 with a pH less than 7.2 is an indication for ventilation. If the CO2 is greater than 55 with a pH near normal, that usually means that we're not going to be providing any mechanical ventilation because the patient lives there. So with patients that are chronically compensated, a lot of times we look at trends of CO2 and pH that can be very helpful to understand if the patient's running into trouble. So these patients are going to probably be receiving multiple ABGs, or we're going to be trending this information other ways with like capnography, non-invasively, or those transcutaneous monitors. More places are getting into doing that now. So that presence of that acute respiratory acidosis indicates one of three major problems. So the respiratory center, that's central nervous system, is not responding properly to the presence of that elevated CO2 in the blood. So it's not sending, something's dysfunctional up in the brain, and it's not sending those impulses to speed up ventilation or respiration. Scenario 2 is where that center is responding normally. It's sending those impulses to breathe faster, but that signal's not going through to the respiratory muscles. So that's your neuromuscular diseases again. So your Guillain-Barré, your myasthenia gravis, those ALS, those diseases that the signal left the brain, the control center, but never made it to those muscles to tell them to take a breath in. And then the third scenario is you've got normal neurologic response mechanisms, but there's an issue with your lungs, your lung compliance or your airway resistance, or your chest wall that's making it incapable to provide that adequate ventilation. So you either have a disease like with your lung compliance, a disease with your airflow or airway resistance like COPD, or you have issues with your muscles, respiratory muscle strength, like muscular dystrophy. Okay, so Okay. Assessment of respiratory muscle weakness. So it's common in these neuromuscular diseases. Um, for patients to have muscle weakness. But it can also happen in our COPD patients or those patients with kyphoscoliosis because of that work of breathing that those patients have. So the tests that we do for this, and again, this is important to remember, anytime you suspect a patient has like a decreased or you suspect the patient might have an issue with muscle fatigue, you want to get a MIP and a vital capacity on them. So a MIP of greater than 20 is inadequate, but watch trends. So greater than 20 means, if it's more positive. So -15, -10, -5, those are all greater than -20. Okay, mathematically speaking. Values less than -20 are good, meaning if I'm able to suck in a -30, -40, that is good. That means I've got good inspiratory muscle strength because I'm being able to suck up more negative pressure. Um, so usually we trend this, typically with our neuromuscular patients, we're doing this, at least TID, sometimes more frequently, just to watch to make sure that they're not going into that ventilatory failure. Your Egan's book says that vital capacity and MEVs are kind of limited in the ICU setting, but I did put it back in here just to remind you that some of your patients you're going to be watching on the floors, and looking for this sign before moving them to the ICU to get intubated. So that vital capacity of less than 10 milliliters per kilogram, or really just a simpler way, sometimes this comes up on board exams, that anytime that they demonstrate a vital capacity of less than 1,000 milliliters, instead of doing the math out, just know that that's bad and say that you need to intubate. Okay. And this is always going to be this kilogram is always going to be per ideal body weight, which you will learn to calculate and you will commit to memory because this is probably the most used calculation that you are going to do as a respiratory therapist, is your ideal body weight calculation. So respiratory muscle fatigue is a condition where that loss of capacity to develop force or velocity of those muscles, this is usually reversible with rest. So after we rest the patient, it's going to get better. So this can either happen because of the demands on the muscles, like we're making them, breathe really fast or breathe really deep, or because of lack of proper nutrients. So that can happen a lot in our ICU patients, especially if they've been on the ventilator a long time and not eating. They might be lacking the nutrients to successfully wean off the ventilator. So there's kind of three types. There's a central, which is happening because of reduced muscle force due to impairment of that central or motor neuron drive. You can have the peripheral fatigue. This can happen because the muscle force with high frequencies, meaning that there's like some impairment of that neuromuscular junction, or it can be coming from low frequency fatigue where it's due to like decreased contractility. So those are kind of just the three types of fatigues. Not super important that you have those all memorized, but just kind of important to kind of at least get exposed to it. So respiratory failure can happen anytime weakness, fatigue, or failure overlap. That's going to result in either acute or chronic failure. Excessive worker breathing is probably the most common cause of that fatigue and failure. And that worker breathing, again, is the amount of pressure needed to move a given volume of air into the lungs. So it's whatever work I need to overcome the compliance of the chest wall and the lung tissue and overcome the airway resistance. We also have imposed worker breathing in ventilated patients, and that can be because of the endotracheal tubes, as I mentioned in airway management. The endotracheal tube is going to be the narrowest part of that patient ventilator interface. So that is going to be the area that's going to cause the highest increase in airway resistance. So the size of ETU tube you choose can greatly affect the patient's work of breathing. The ventilator circuit can also cause increased work of breathing to the patient, depending on if there's extra dead space in it. If there's any presence of autopeep, as I mentioned before, you have to overcome that pressure that's already in the alveoli in order to create that pressure gradient in order for volume to enter there. And then different types of disease processes that happen during ventilation or during intubation and mechanical ventilation like ARDS, that can increase work of breathing. So we have one option for putting a patient, not intubating a patient and kind of avoiding some of the complications of intubation like ET tubes and things like and vent circuitry and dead space, is using non-invasive ventilators. So these are your BiPAPs, which you guys all got exposed to during the summer, hopefully a little bit. This is defined as any mode of ventilator support that does not use an endotracheal tube. So it can include just straight CPAP, where we're just using one continuous pressure that the patient breathes in and out against. And then you can use that CPAP in combination with any pressure limited or volume limited ventilation. Okay, so this is going to make a little bit more sense when I show you the next side. So typically this is just a picture of a V60 screen, which is a very common, or had been a very common non-invasive ventilator that people use at the hospital. We have one in the classroom that we'll use in lab. And when you're setting BiPAP, again, the patient's going to be wearing a mask, hooked up to the vent circuit to create this closed system. The machine, all mechanically ventilator machines, whether it's non-invasive or invasive, you can kind of think as just big flow meters that have fancy buttons to tell you when to turn the flow meter on and when to turn the flow meter off. So flow is going to exit the machine, and because that machine is a closed circuit with the patient, it's going to create a pressure. Okay, how much pressure we create, that pressure gradient that we create, is what's going to cause volume to enter the lungs. Okay, so if I have really, really stiff lungs, I might need a bigger pressure gradient to get that volume to move. If I have really, really, really compliant, pliable lungs, I might need less pressure gradient to get that volume to move. Okay, so the pressure gradients are created by something called an IPAP, which is your inspiratory pressure, and your EPAP or expiratory pressure. Sometimes you can think about expiratory pressure a little bit like CPAP because it's that constant pressure that's always there in the lungs. So if you look at this pressure waveform here, this line here with the gray underneath represents that time the patient is spending at that EPAP level, okay, during expiratory phase. This top line here represents the time that the patient's spending at its inspiratory pressure. So when I want the patient to breathe in, the ventilator, this non-invasive ventilator, sends extra flow down through the circuitry that's creating this higher pressure. It's going to do it for a preset amount of time. This is my inspiratory time, how much time I spend in inspiration. And then it drops back down to a lower flow so that it's creating that lower pressure. Okay, that the patient just kind of keeps in their lungs during that expiratory phase, and that just helps keep those alveoli open. Okay, a lot of times we set a backup rate as well, just to make sure that our patient breathes a certain amount, minimally a certain amount of time a minute. So somewhere between 10 to 16 usually is adequate. And then finally, this rise time, this just indicates how fast it takes me within this inspiratory time to get up to my set pressure. So it changes the slope of this line here. So I can have it be more like a box like this, or if I want it to be a settle higher rise, it might look more like a triangle because it takes me longer within that inspiratory time to get up to that eye. We will go through why you choose what you choose very in depth later on, but just to kind of give you some explanation of the settings. Okay. So the goals of non-invasive ventilation improves hypoxemia, hypercapnia, and that's through compensating for that inspiratory threshold load from that auto PEEP. So if I didn't have, if I wasn't on a non-invasive ventilator, I would have to create this amount of pressure gradient all on my own with my inspiratory muscles. But by using BiPAP, the machine is going to make that pressure gradient for me so I don't have to work as hard. Okay. So it's going to help me increase my tidal volume. It's going to take that workload off of my respiratory muscles. A side effect of it, whether it's good or bad, sometimes it's good, sometimes it's bad, is it does reduce the amount of venous return. If you think about your thoracic cage, again, I drew this picture for you last year. Your thoracic cavity is a box, and inside that box, you have your lungs and your heart. So it's a box within a box. Your heart's kind of a box within a box. And pressure, any pressure I add to the thoracic cavity or thoracic cage is going to put pressure on the outside of the heart. Okay, so if I increase the pressures in the lungs, which increases that thoracic pressure, more pressure is going to be put on the outside of that heart muscle, which makes it harder for that blood to return to the heart. Okay, if blood doesn't get to return to the heart, then blood doesn't get pushed and pumped out of the heart. So that can be a good and bad thing. In some diseases like congestive heart failure, reducing that venous return really helps with that left ventricular afterload and makes it easier for the left ventricle, which isn't working very well, to manage better. But in a normal healthy patient, if I reduce the venous return, that can make my patient hypotensive, which would be a bad thing. So this one goes either way. By kind of having that that EPAP level, I can maintain a good alveolar recruitment. We use PEEP purposely in ventilation to recruit alveoli that don't want to open up and keep them open. It's used most often in patients with sleep apnea to try to prevent the narrowing or collapsing of that upper airway in obstructive sleep apnea. And because it helps with that alveolar recruitment, it's going to increase that functional residual capacity. And if you remember from CP Phys, functional residual capacity is the volume of air that stays in our lungs after normal exhalation. So what I'm breathing right now, after I exhale normally, there's going to be a certain amount of air that stays in my lungs to keep those alveoli open, make it easier for me to take my next breath. That is called my functional residual capacity. It is made up of my residual volume, which I can never exhale, and my expiratory reserve volume, which is a volume of air that I can forcefully exhale. So this is my normal respirations, normal tidal volume breathing. If I would be exhaling all the way to my expiratory reserve volume, that would be me like pushing and forcing more air out of my lungs than I normally would. So non-invasive ventilation in acute conditions, it's used a lot for exacerbations of COPD. So it's considered kind of standard practice. Most COPD patients are going to choose doing non-invasive first to try to avoid the complications of intubation. We use it a lot too as kind of the first line of defense for cardiogenic pulmonary edema, or another word for that is congestive heart failure. Acute asthma patients, this is a little controversial, but more recent studies have come out to show that this can be very successful. Not all asthma patients are going to be managed successfully on non-invasive. Some of them do fail non-invasive trials, but the ones that are successful, because you never intubated them, they're going to have a lower reduced length of stay, and then they're going to have a reduced mortality, because anytime we don't intubate somebody, we're going to improve their chances of survival. Acute lung injury and ARDS. So these ones are not as recommended. Typically, we want to go with high flow for ARDS and acute lung injury patients. That trying to manage them on because really a lot of times these patients' issue is just oxygenation, not ventilation. So managing them on like high flow therapy for as long as possible is going to reduce the amount of days that they're on the ventilator overall, which can reduce their mortality rates. But there's not there's not a lot of strong evidence to show that non-invasive works well for those patients. So in chronic conditions, non-invasive is used very widely in obesity hypoventilation syndrome. So those are those patients who have a really high BMI, and because of their body habitus, they have a hard time ventilating effectively. You know, their chest wall is very rigid, non-compliant, making it hard to ventilate against that. So they usually shows with obesity hypoventilation syndrome, their CO2s are usually going to be really elevated even during the daytime. These are the patients also that you're going to see in those chronic ventilatory failures, fully compensated respiratory acidosis. And typically those patients, when they're managed on non-invasive at home, they're going to be put on something called volume assured pressure support, which is AVAPS, where we're targeting a specific tidal volume for the patient, and fluctuating the pressures to achieve those volumes. So that's typically what they order those patients on. Stable COPD patients also get sent home with non-invasive ventilators to help them out at home. This is one of the biggest tips I can give you as future little respiratory pros that are going to go out there, is those COPD patients that you are constantly seeing in the ER and putting on BiPAP for a day and then they go home. Look to see if they qualify. So many times we miss an opportunity to try to qualify our patients for non-invasive ventilation at home, which has really been shown to prolong survival, improve that quality of life, and drastically reduce hospitalizations if we give patients these tools to use at home. When these patients go home with these machines, they're usually put on really, really high IPAP levels and low EPAP. So there's a huge pressure gradient there that helps with them achieving their volumes, and they have a backup rate. And as always, I mean, they kind of lumped it in with the COPD patients, but it's really everybody. Non-invasive does somewhat have a low compliance rate. Patients on non-invasive ventilators, BiPAP machines, you probably maybe saw this over summer clinicals. A lot of patients don't wear these appropriately or don't want to wear them. There's a lot we can do with interfaces to try to make them more comfortable, adding humidifications, things like that, to try to work with our patients and make them more comfortable. Sometimes, though, I'm a realist, and no matter what you do, they're still not going to want to wear it. So, you know, work within your means. That is a reason to intubate somebody, is if they're non-compliant or won't tolerate just using the non-invasive devices. Neuromuscular disease patients also can use non-invasive at home. So myasthenia gravis patients, ALS patients, things like that might be sent home with a BiPAP machine or non-invasive machine to try to, again, improve their quality of life, reduce those hospitalization rates, reduce that risk of pneumonia, because they're able to ventilate more appropriately and reduce risk of atelectasis. All right. So invasive support, when we're talking about invasive support, we're talking about now we're intubating the patient, putting them on a ventilator, okay? So anytime a patient has profound hypoxemia requiring intubation will require intubation and mechanical ventilation. Other indications, okay, where you shouldn't attempt non-invasive at all is any presence of upper airway obstruction, right? So if there's any evidence in the scenario you're given that the patient has an upper airway obstruction, you need to intubate, okay? The patient inability to clear secretions or protect their airway. So if the patient is coming in with seizures, they can't protect their airway, you need to intubate. The inability to achieve a proper mask fit, meaning they've have some sort of facial trauma, facial burns, you need to intubate. Or finally, as I already mentioned, if the patient is not tolerating the non-invasive, is taking the mask off, is refusing to wear it, they need to be intubated. Um, so ARDS, I mentioned before, ARDS is not a very good, ARDS patients aren't good candidates for non-invasive. They high flow therapy or early intubation is usually kind of indicated. So those profound hypoxemic respiratory failures, usually ARDS or severe pneumonia is going to be the cause. Do your PF ratios. That can be very helpful. These patients are going to have very non-compliant lungs, meaning that it's going to need a lot of pressure to open up the lungs so that it will receive volume. Because you're using such high pressures, you really don't want to try to overdo it. Usually, typically, we don't want to have a big pressure gradient because that increases your risk of something called barotrauma, which is pressure trauma. So typically we ventilate these patients with small tidal volumes. Okay, and we're going to talk about this more. But small tidal volumes, meaning tidal volumes, we usually start at 8. The recommendation is usually start at 8 milliliters per kilogram, but wean that pretty quickly to reduce the risk of complications. And you can go all the way down to 4 milliliters per kilogram. The goal is to get your plateau pressures below 30. And again, I'm just putting that term out here into the world to write down on your cheat sheet and save for the rest of your life. But we'll talk more about what plateau pressures mean in during week 3 and week 4. Okay. But right now it's just important to know plateau pressures less than 30 is how we manage our patients, our goal for managing our patients with ARDS. So just understand that you sometimes are going to be managing patients like head trauma patients or patients that have risk for increased ICP with ventilators. This is a very controversial, sticky one too. Okay. Short-term hyperventilation can alleviate spikes in ICP. I'm going to highlight the word short term. Okay, this is not a long term solution. But if you have a patient who has spiking their ICP, you can increase your respiratory rate to try to drop, to kind of increase your CO2 or decrease your CO2 quickly, and that will decrease your ICP. Okay, and but long term, we want to try to maintain our patients still within the normal range, but on the lower end of the normal range for our PaCO2s. This just helps us in case we have another spike in our ICP and we want to do this really quickly for a short-term solution, but we don't want to maintain our patients' CO2s chronically low and chronically hyperventilating them to try to chase some ICP ideal. Also remember, PEEP may increase that right-sided heart pressure, that CVP. If that CVP is increased, that means the venous return from your head is going to be decreased, which can then again elevate your ICP. So be careful with your PEEPs on your patients with increased intracranial pressure. Other ways we can alleviate ICP, increase ICP, is by elevating the head of the bed. And if the patient's unstable, they usually have like an ICP monitoring. Be also very careful with suctioning these patients and trying to not reduce any agitation with them. Okay, with our COPD patients, we're usually going to optimize our settings. And this probably can be a little bit true of a lot of the patients that you're going to see on ventilators, mostly because most of your patients that are on ventilators are going to be COPDers. So you want to do lower tidal volumes as well. This range is somewhere between 6 and 8 milliliters per kilogram, which is probably true of most of your patients. Most patients, except for your ARDS patients where you can go as low as 4, you want to pick a tidal volume between 6 and 8 milliliters per kilogram. Okay, moderate respiratory rates to try to compensate, make sure you're blowing off enough CO2 for your COPD patients, but typically initial respiratory rates are going to be set somewhere between 10 to 16. we're going to be talking about waveforms, and what the differences between waveforms in the next couple weeks, like a square waveform, decelerating waveform. That's all to do with how the flow is delivered. So do I want the flow going in really fast, or leveling off, and then decelerating? How do I want that flow to be delivered to my patient? That is going to affect sometimes about, uh, we're going to do that to try to overcome things like airway resistance and lung compliance issues. So, a big thing with using high flow rates is because if I'm getting the breath in faster, that volume gets delivered faster. That means my inspiratory time is shorter, which is huge when it comes with our COPD patients because we want a longer expiratory phase. Okay, remember, obstructive diseases affect flow rates. I get to pick the flow rate that my patient inhales with, but exhalation on mechanical ventilation, just like in normal breathing, is passive. It's going to be whatever product of that airway resistance and tidal volume that patient has. So if I give that patient with a severe COPD patient longer time to exhale, they're going to be able to eliminate more of that volume. Less of it's going to get trapped in the lungs, and less likelihood to cause that hyperinflation and intrinsic PEEP, minimizing that auto PEEP. But we do want to set our PEEP to help alleviate any work of breathing or any asynchrony with that auto PEEP. So we can talk we will definitely dive deeper into how these things get set later on in the semester. And finally, final reminder, the goal is always to normalize your pH, not your CO2. Especially in these COPD patients or these chronic hypercapnic patients. I don't care what their CO2 is as long as that pH is within that 7.35 and 7.45. Okay. If you try to normalize that CO2, that's going to cause that metabolic alkalosis, which could cause a patient to have seizures, arrhythmias due to hypokalemia. So you want to avoid that. Obviously, those are bad side effects. So we're not normalizing our CO2, we're normalizing our pH. And if we are trying to normalize that CO2, we set the wrong goals, that's going to prolong our time on the ventilator, which, puts our patient at risk of those complications like infections, delirium, other complications from being in the ICU too long and on the sedatives you need to be on for to have effective ventilation. So the quicker we can get them off the ventilator, the better their outcomes. All right, sorry, that one was quite a bit longer than the hour that I usually try to make these, but I didn't want to make 3 different parts. So that was a long one.